Good evening, all the aspirants. Here we have the speaker, Dr. Varun Arora, who is a consultant at BLK Max Hospital, Delhi. Thank you, sir. You may take over.
Thank you. Good evening, everyone. My name is Dr. Varun. So we are going to discuss questions regarding general topic today. Uh, the questions which come in general topic are those questions which have not been discussed in any of the systems. So we'll start directly with the questions without wasting your time. So I hope you all have been given the questions beforehand. Am I right? Or are we going to discuss the questions just now?
So I would say because of the late, we have uploaded in the portal late. So you can, ask the question and then discuss the answer. It's better
Okay.
because
Okay.
I believe many of the aspirants may not have completed the session,
Okay. Okay.
the
Okay.
question.
Just now
Thank
you
you.
got the questions. Okay. Okay. I got a message from someone that just now you got the questions. So Sana has said that we will discuss the questions one by one. So this is a question. I would request all of you to read it for someone. One of you can read it, or all of you can read it yourself in 1 to 2 minutes, and then we will discuss. So this is a question regarding 35-year-old woman who has just come to ER with fever, severe epigastric abdominal pain and nausea that has worsened. You can see the vital signs. She is having fever, heart rate 115, blood pressure 90/60, respiratory rate 19, oxygen saturation 93%. After all the samples were taken, she was given 4 liters of lactated RL. This is a very important thing that she has been given 4 liters of IVF. She has been given IV morphine for pain and started on some of the antibiotics. You saw that a ultrasound abdominal scan was performed where pancreas appears inflamed but no necrosis or cyst is noted. So till now you must have taken the note that the patient has got acute pancreatitis. So this is very important that in the middle of the question you have diagnosed the patient. So this is very important in all your EDIC questions. You need to be very fast. So this patient has acute pancreatitis. Now we'll go on the second half of the question. ICU doctor came after 4 liters of crystalloid. All these vital signs have been given. Laboratory tests are available. So now we will see what the examiner wants to ask you. So who will give me the answer? Then we will discuss. Anyone who can give me the answer? D. Very good. Someone has given D. So
So
first we will
A, city.
yes. The answer which I got is D. So we will review all the options. So A is immediate CT. One of you has said CT. CT is not diagnostic for acute pancreatitis. If you see the acute pancreatitis, epigastric pain plus amylase and lipase 3 times the normals. This is the definition. Only when you have epigastric pain and you are not able to find out what the diagnosis is, then you always go for a CT. Immediate CT is not always required for diagnosis. It can give prognostic information, but the answer says will provide the most prognostic information. Most prognostic information, we have got some kind of scoring systems which will give you prognosis. So immediate CT is not required for diagnosis. Immediate CT is not required for prognosis. You will have scoring systems for prognosis. Then second option, empiric antibiotics should be continued. No, in acute pancreatitis, the empiric antibiotics are not warranted. Only if you have got necrosed pancreas or if you have got some sort of infection, either bloodstream infection or pancreatic infection, only then you will start antibiotics. Initially, you should be given bowel rest. This is the third option. No, you have to start because pancreas is a catabolic state. You have to start enteral feeding as soon as possible. Then D option, chest radiography may be helpful. Chest radiography is one of the components. pleural effusion is one of the components of bicep scoring system. So you will obviously go for chest radiography. You will see whether the patient has got some sort of pneumonia also because of acute pancreatitis, or the patient may be landing up into ARDS, or whether there is a pleural effusion or not. So chest radiography will tell you all these things. And fifth option, further IV fluids will decrease the risk of death. Initially, you may want to give a high amount of IV fluid to a patient presenting with acute pancreatitis, but further it is not warranted. She has already received 4 liters of IVF. I think that is enough. So the answer is D. So what is the explanation which is given here? The most widely used system is Apache 2, but it is cumbersome. You always require some sort of online calculator to calculate it. And then there is bicep scoring system. It has got 5 components: BUN greater than 25, impaired mental status, systemic inflammatory response syndrome, age more than 60, and pleural effusion. So one of the components. So what is the importance of bicep? That your mortality increases if your score increases from 2 to 3. So her BUN is more than 25 and she is into systemic inflammatory response syndrome. So already two of these are positive. If there's pleural effusion, then the score becomes 3. So her risk of death or mortality risk increases. So chest X-ray is obviously warranted as a baseline investigation also, and to have a scoring system of pancreas. So let's go to the next question. So you can read this later, and you should know in pancreas all the scoring systems, including the CT scoring system. And what is the definition? When you have to start for pain, when you have to start for antibiotics, how much fluids you need to require, whether nutrition, enteral nutrition, what are its benefit, parental nutrition, what are its disadvantage. So all of you know when to start antibiotics, how to diagnose cyst, how to diagnose the necrotic pancreatic tissue. So all these you should know in your pancreas case. Next question. A 25-year-old brought to ER for lethargy and confusion. Family saw her 8 hours ago, and EMS personnel found an empty bottle of paracetamol, acetaminophen, at the scene. GCS 10, she's hypotensive, requires 2 liters of IV, bolus to stabilize her BP. Lab findings you can see, you can read. pH 7.35, CO2 35 normal, PO2 95 normal, acetaminophen level is 400. So at this point, you should know how much are the acetaminophen levels. This you have to mug it up. ECG shows NSR. So what is the next step in the patient's management? Someone has written E, N-acetylcysteine. Can you tell me why? Any of you? So we'll go by one by one. A option we will rule out. Naloxone. Why? Because patient has not taken opioid. This woman has taken acetaminophen. So naloxone is ruled out. Vasopressors is ruled out because after 2 liters of bolus, the BP has gone up. Intubation is not required because her GCS is 10. If it was less than 8, then intubation is required. Observation, you can go, but right now she has taken large amount of acetaminophen and level is 400. Above 500, it is detrimental. So observation is also ruled out. So last option left is N-acetylcysteine. So let's see the. So it is one of the most common drug toxicities in Western world. And obviously, if you're giving your EDIC exam, you will be asked about one of the questions will be there regarding the poisoning and toxicity, and acetaminophen or paracetamol is the most common in Western world. So there are 4 clinical phases of acetaminophen toxicity. 1, 2, 3, 4. You can read about this. 4 is the recovery. 3 is jaundice, hypoglycemia, and coagulopathy. This is not seen. So probably this woman is in first phase. So she is still responsive to IV fluids. Naloxone has no role. And obviously there is a metabolite of acetaminophen, which is NAPKI. So once your NAPKI levels increases, your glutathione levels goes down. So to maintain the glutathione reserves, you need to start the patient on NAC infusion. And these patients are stratified according to the Rumac Matthew nomogram. All high-risk patients should be started on NAC therapy, preferably before elevation of your enzymes and continued as long as your enzymes do not rise and your acetaminophen levels are undetectable. So if your levels are greater than 500, more than 500, you need to transfer this patient to a liver transplant center. The levels here are 400 and not 500. So the best possible option which we can do at this point of time is to start the NAC infusion. Let's go to the next question. So this is like sextagal Blakemore tube for management of esophageal varices. So which statement is true? So first it has got 4 ports. No, it has got 3 ports. 4 ports is in Minnesota tube. It must be stored at 4 degrees Celsius. No, it is not right. It should not be always stored. You can store it in your refrigerator at 4 degrees Celsius, but not always. Requires insertion via the oral route. No, like a Riles tube, like your orogastric tube, you can insert through nasal route also. So it can be inserted through either nasal route or oral route, whichever is available. Rebleeding is common after deflation of the gastric tube. This seems right because in 50% of the cases, once you deflate your tube, you will find the rebleeding. That is why this Sengstaken Blakemore tube is not a preferred therapy. It is only done in cases where you don't have your gastroenterology referral available or you don't have your endoscopy readily available. So it is no more done only in centers with resource limiting settings. We go for the Sengstaken Blakemore tube. So rebleeding is common and the fifth option says that the tube should be removed within 12 hours. No, you have to keep it for 2 to 3 days at least. So we will see the explanation. So Sengstaken Blakemore tube helps in control bleeding in 90% of the cases. However, you will find rebleeding in 50% of the cases, which was one of the true options in this. Minnesota tube has got 4 lumens, uh, 4 ports, and this tube has got 3 ports. You can insert it by nasal as well as oral route. And it should be usually removed within 36 to 48
So
hours and not within 12 hours as was given in this option. Okay? You have to remember all these things. Now, trolley. Please read the question and then one of you can answer me.
which statement regarding transfusion-related acute lung injury is true? So answer is C, sir. It is immunological diagnosis.
No, it is not a immunological disease. Anyone else?
E.
It is not physiological. They have asked what is true. Which of the statement is true? So first statement, it is
So volume already consult problem.
so volume overload is a principal problem. No, it is not a volume overload problem. Then second, mortality ranges from 5 to 25%. So in ARDS, you have seen that your mortality is around 25-30%. So it corresponds to your ARDS. It is an immunological diagnosis. It is IgA mediated. No, it is not physiologically distinct from acute lung injury. So TRALI always is same as acute lung injury, or you can say ARDS. So we'll see the explanation also. It is a clinical diagnosis based on the temporal relationship between transfusion of blood products and the development of acute lung injury, usually developing within 6 hours of transfusion. But even after 24 hours, in some of the questions you will see, even after 24 hours, if the patients develop some sort of respiratory difficulty, you have to consider TRALI as one of your differential diagnosis. Patient may be in fluid overload, But you cannot say that the patient has got trali. Trali only you will see when you have got X-ray and PEEP more than 5. Whatever the definitions of ARDS are there, when the patient fulfills that, then only you will call the patient as having acute lung injury. So mechanisms of trali and acute lung injury are same. That is capillary leak and non-cardiogenic pulmonary edema. So patient, once you are giving blood products, patient may land up into fluid overload, but trali is not fluid overload. Now next question, please read it.
So a previously well 45-year-old man is assaulted with a baseball bat and sustains a left-sided subdural hematoma. On arrival in emergency room, his GCS is 5 and he undergoes an emergency craniotomy. Following evacuations of the hematoma, he is transferred to ICU. 12 hours later, he has brief tonic-clonic seizure, which is self-terminates. Which statement is false?
So you have to find out a false statement in this. So you should have
Yeah.
knowledge about the post-traumatic seizures. There are two kind of post-traumatic seizures, one early, which happens before 7 days, and late. So you have to find the false statement. So let's see the first statement. All your hematomas, EDH, SDS, they carry an increased risk of seizures as compared to diffuse axonal injury. In diffuse axonal injury, patient will be in vegetative state and will not be having seizures. He may have seizure, but the incidence of seizures is more in SDH, EDH, penetrating brain injury, or some sort of hematoma or bleeding. Then second, prophylactic phenytoin is effective in preventing early. Yes, it is effective. Both phenytoin and valproate are effective. Even some studies now, the recent studies indicate that your levetiracetam is also effective. So all these first line anti-epileptics, that is phenytoin and valproate, both are effective. And prophylactic anticonvulsants do not reduce. Yes, it is true. Only for early post-traumatic seizures, they are effective. Prophylactic anticonvulsants improve outcome following traumatic brain injury. This is a wrong statement.
Okay.
It is reasonable to start this patient because the patient has just come to you and prophylactic phenytoin is effective in preventing early PTS. You can start this patient on phenytoin. So let's see the explanation also. You can read. This you have to mug up. So they are classified as early or late. Risk factors include subdural, extradural, or intracerebral hematoma, as I've already told you, depressed skull fracture, and penetrating head injury. Both phenytoin and valproate can be given, and they have been shown to reduce the incidence of early, but not late PTS. So only if you have a specific indication for continued therapy, only then you will continue. Otherwise, they are not warranted beyond 7 days. So this you have to learn and apply in exam. Next, regarding the administration of recombinant factor 7A, all of you read the question and then we will discuss. So the answer is A, someone has given it. So its use is associated with 1 to 2% incident of thromboembolic complications. Half-life is not 12 to 15 hours. Half-life is usually around 3 to 4 hours. The option C says that it is given in physiological doses for management of major hemorrhage. First of all, you should know what are the indications of factor 7A, recombinant factor 7A. The only indication are hemophilias. For the management of major hemorrhage, it is off-label indication and you need to give supra-physiological doses, not the normal physiological doses. And one more important thing is that recombinant factor 7 is very, very expensive, even in Europe. So if you see that it is expensive in one of your options, it is always right. It is licensed for the treatment of major obstetric hemorrhage, no. DIC is common complication of treatment, no. So the answer is A. You can read the explanation. 1% thromboembolic complications in hemophiliacs and 1.4% cases in non-hemophilia coagulopathy. Short half-life, 2 to 3 hours. I used to remember it is 3 to 4 hours, but they have written in 2 to 3 hours. It is given in large supraphysiological doses for major hemorrhage, which is an off-label indication. Regimen is 200 milligrams per kg, followed by 100 milligrams per kg at 1 and 3 hours. License indications are prophylaxis and treatment of bleeding in patients with hemophilia A or B and inhibitory antibodies or acquired factor 7 deficiency. So it is not for obstetric hemorrhage, it is not for trauma. And DIC is rare as a consequence of recombinant factor 7A treatment. Now, question number 7. You can read and then we can discuss. So you have to rule out certain things. You have read the question. Now we will go. Persistent vegetative state looks more likely, but we have to rule out the other things also. So he is in a vegetative state. Minimally conscious state. Yes, he can be in a minimally conscious state, but there is something written that he shows no recognition of his surroundings. He flexes to painful stimuli, but will not follow a command. So minimally conscious state is rule out because there is no recognition of surroundings and he is not following any command. Only on pain he is flexing. Coma, even on painful stimuli, a patient will not respond. So coma is ruled out. Brainstem dead. Brainstem dead is ruled out because patient has got spontaneous eye opening during waking hours. He is following a regular rhythm. During waking hours, he is opening his eyes, but during night time, he is sleeping. So brainstem dead is also ruled out. Locked in syndrome is ruled out because patient can usually respond by blinking of the eyes or movement of your pupils. But at this point, he is having no recognition and does not follow command. So looks like patient is in persistent vegetative state. So this is the explanation. So the term permanent vegetative state may be used after 12 months and implies minimal likelihood of improvement. Minimally conscious state is a variant of persistent vegetative state, but these patients retain some degree of awareness. They may be able to obey a simple command and have limited interaction with their environment. So patient is not in minimally conscious state, but in persistent vegetative state. So coma, eyes closed, unconsciousness. It is written over here. You can read these explanations later on. Brainstem death is diagnosed by loss of all cranial nerve reflexes and loss of cardiorespiratory homeostasis. You will see your BP and heart rate fluctuating a lot, and patient probably have no spontaneous efforts. This is you will see in your brainstem death. In locked-in syndrome, your awareness is preserved. So the diagnosis here is persistent vegetative state. You can read the explanation later on, and you should know all these terms. Now read the question number 8. I'm giving you 20 to 30 seconds. You have to be a little fast here. This is regarding Clostridium difficile. You must be knowing the latest guidelines which are there for C. diff. You can just note down the gist of that guidelines, the highlighted portions, the recommendations which they have given. You don't need to read all the whole guideline, just the important points, the summary, and you will be able to answer all your questions regarding Clostridium difficile infection. So this patient has got recurrence of C. diff infection, as you can see by history. Patient was already having C. diff. Now again, she has presented with C. diff. So at this point of time, your oral metronidazole will not work. Probably at your uh, first case of when she was diagnosed initially, you can give oral metronidazole, but not with recurrence. Second is oral vancomycin 125. This is a dose. Usually dose is around 500 TDS to QID. Fecal transplant, yes, it can work, but it is a last resort therapy. Oral fidaxomicin, yes, someone has written also in the answer in the chat box. So oral fidaxomicin is the recent drug which is there for the recurrence of C. diff infection. Oral rifampicin you can give, but it is not recommended as per the guidelines. So you should know the guidelines. You can read this explanation also. Severe cases not responding to oral vancomycin should be either treated with high dose oral vancomycin like 500 QID or oral fidaxomicin. Oral metronidazole only with initial insult. And fecal transplant only as last resort. So next question, 9 number, around SBP. You can read the question in 30 seconds. Then we will discuss all these options one by one. They have asked which of the option is false. You have to rule out the wrong option. So the probability of survival at 2 years following one episode of in cirrhosis is approximately 50%. So in EDIC, what happens? You don't have to remember all the uh, survival ratio, survival figure, survival percentage, all these figures. You usually have to rule out the other wrong options which are there in the definition of diagnosis of a particular disease. So even if you don't know about this, whether it is 50%, 20%, 30%, you can see the other options before going with it. So this option is true. I know that because I have read about this. So someone has given the answer B, but let's discuss all the options one by one. So probability of survival is approximately 50%. It looks true to me. But even if you don't know, you can move to other options. This is a single option question. You have to only mark about a single option. So neutrophil count of more than 150. This is wrong because definition clearly says that more than 250 should be the answer. More than 250 neutrophils per cubic millimeter is diagnostic of SBP. So once you have ruled out this negative, all other options become automatically correct. So let's see other options also. So this is a false option because it should be more than 250. Administration of albumin may decrease yes, it is right. It obviously decreases the development of hepatorenal syndrome. Ascitic culture is negative in up to 40% of cultures. Yes, this is also right. In about 1/3 of the patients, you will see that your ascitic culture is negative, but still you will diagnose the patient as SBP based on your ascitic tapping results. A neutrophil count of more than 250 neutrophils per cubic millimeter is diagnostic of SBP. And then your last option, routine antibiotic prophylaxis is recommended who have had one previous episode of SBP. Yes, this is right. Patient who has one previous episode of SBP, you will start the patient on routine antibiotic prophylaxis. So your B option is false. You can read the explanation later on. We'll move to the other question. Following are common lab features of toxic megacolon. So what happens in toxic megacolon? You will have lots and lots of RT aspirate or vomiting. So there is loss of HCl, hydrochloric acid. So you, along with other electrolytes. So you have metabolic alkalosis. This is right. Patient will have hypokalemia. This is right. Raised hematocrit will not be there. Patient will have decreased hematocrit. He will have some amount of bleeding through his colon. So patient will have anemia along with decreased hemoglobin or decreased hematocrit. And leukocytosis with left shift. What does it correspond? Leukocytosis. Patient will have inflammatory response. And during this inflammatory response, your bone marrow will start producing lots of leukocytosis. So patient will have leukocytosis with left shift. You can see the explanation also. You can read it and then we'll move to the next question. I'm giving you 30 seconds. Moving to the next question. Regarding the pathophysiology, management, and treatment of necrotizing fasciitis. So you will have two questions on necrotizing fasciitis during our current discussion, and it is a very favorite topic of European people. So read the options. I think it is a true false question. No, you have to mark every statement as true or false. So read all the options one by one. So let's discuss. Mortality is directly proportional to time to intervention. Yes, this is right. The more you delay, the more chances of aspiration. Yes, so this is true. Second, the most common type of necrotizing fasciitis is caused by group A streptococcus. No, this is false. I'll tell you the four types of
D.
necrotizing fasciitis. The most common type is polymicrobial. Then you can remember your second type is due to gram-positive infections, either by streptococcus or staphylococcus. Gram 3, sorry, Your type 3 is by gram negative, most commonly due to Vibrio cholera, and type 4 is fungal. So type A is the most common and it is usually polymicrobial infection, which is the most common type. So this statement becomes false. Skin changes are a common early presentation. No,
All right.
skin changes are not a common early presentation. You will have pain before skin changes. Surgical debridement must be performed. Yes, this is right. This is the only therapy. Your source control, surgical debridement. It should be performed as soon as possible because your antibiotics are not able to penetrate the infected necrotic tissue. And clindamycin first line monotherapy. No, you have to give a broad spectrum antibiotic along with clindamycin. Clindamycin will decrease your toxin production, but you will have to give because your infection is polymicrobial. Only when you have got your culture sensitivity report, you can single out the agent, not before that. So we will read the explanation. It is a clinical diagnosis and most serious presentation of necrotizing soft tissue infection. So there are four types. Type 1, most common form, polymicrobial. Type 2, streptococcus, with or without staphylococcus. Type 3, gram negative, most commonly by Vibrio species, uncommon but carries a high mortality. Type 4 by fungus. So all the infections start at the level of subcutaneous fat and deep fascia, and that's why you will not see your skin changes early. You will see in your later stages of the disease, skin bullae, blister, skin fluctuation, necrosis, all you will see in your later stage of the disease. Antibiotics are unable to penetrate infected necrotic tissue. So aggressive surgical debridement is the mainstay of treatment. It should be your first priority. Our empiric therapy includes a broad spectrum agent, which can be combined with clindamycin because clindamycin is known to switch off the toxin production. If MRSA is suspected, you can give linezolid because it inhibits the exotoxin production. Okay. Now, question number 12. Please read it and then we can discuss the options. We have to mark the best choice of antimicrobial therapy in this patient who has got a Panton Valentine leukocidin producing Staph aureus, PVL, Staph aureus. So, what should be your therapy for PVL, Staph aureus? PVL you will see in community acquired MRSA. In hospital acquired MRSA, you will not see PVL. In community acquired MRSA, you will see your Panton Valentine strain. So PVL is a very dangerous strain. You can give flucloxacin for MRSA, but in PVL in necrotic tissue, your flucloxacin will not go. So first option is ruled out. Addition of intravenous immunoglobulin. Yes, you can add, but it requires more. It requires a anti-MRSA treatment. So only not just addition of intravenous immunoglobulin, you have to give intravenous clindamycin also and linezolid also. So along with your intravenous clindamycin, linezolid and rifampicin, you add intravenous IVIG. So C options looks correct. Intravenous vancomycin. Vancomycin is not a good drug for your lung. And for your, I'll tell you the explanation. And nebulized pentamidine, it is not also recommended. So we'll see the explanation. So here they have written that vancomycin is not recommended due to poor extracellular fluid levels and penetration of lung tissue. So you will not find it in extracellular fluid. So it is not recommended. And there is little evidence to support the benefit of nebulized pentamidine. The consensus recommendation is clindamycin, linezolid for toxin clearance, and rifampicin for intracellular clearance of staph. So in addition, IVIG at 2 grams per kg should be strongly considered as adjunctive care for its ability to neutralize exotoxins and superantigens. So you should be knowing about MRSA because you will get one or two questions on MRSA. What are the MRSA antibiotics? In which cases you think that the patient has MRSA, suspected MRSA according to surviving sepsis guidelines. So you need to remember, you need to mug up all these things and how to treat MRSA. What are the agents which are available for clearance of MRSA? Now, this question regarding infection control and methods of cleansing and equipment. So you must be knowing about the five moments of hand hygiene before touching the patient, after touching the patient, before touching the surroundings, after touching the surroundings, and after doing any procedure. So after touching any projects in the patients, you should always wash your hands. So this is right. This is, I think, true false question. Matching Michigan was a patient safety initiative to decrease the incidence of VAP. No, it was for CRBSI. You have to learn this thing. So this is false. 2% Chlorox with 70% isopropyl alcohol sterilize. No, it doesn't sterilize, but it disinfects the skin. So you should here know the difference between sterilization and disinfection and what types of disinfection are there. I'll discuss in the explanation. Pulse oximeter probes must be decontaminated. Yes, it is right. Any item which comes into contact with must be disinfected before subsequent. Yes, this is also right. So any item which comes into contact with sterile tissue, like whenever you are performing your surgery, you are going inside the body, all the tissues are sterile. So that should be sterilized. If it is coming into contact with mucous membranes, like your oral thermometers, oral temperature probes, they are coming with bronchoscopes, endoscopes. They are coming in contact with your mucous membranes, but not invading the sterile tissue. So these should be disinfected. And decontaminated means like these pulse oximeter probes, which are on the intact skin and not on your mucous membranes. So all this explanation you can read later. Remember, there's a difference between sterilization, disinfection, and decontamination. So I'm giving you 40 seconds. If you have time, you can read this. Otherwise, you can read this later also before going to the next question. I think we have 7 questions left. We will cover in next 15 to 20 minutes. Moving to the next question. This is again regarding necrotizing fasciitis we have just discovered. I think this is a true false question. So I'll go through this question very quickly. Skin changes typically precede the pain. No, the pain precedes first. So this is a false option. Most commonly polymicrobial, the type 1, which we have just discussed. So this is a true option. Intravenous antibiotic therapy is a mainstay. No, the mainstay is source control. Once source control is done, once your surgical debridement is done, only then your antibiotics will work. Muscle involvement is required for diagnosis. No, it is not required for diagnosis. You will have it in subcutaneous fascia. It is classified according to the location. No, it is classified as per the microbes. Type 1 polymicrobial, type 2 gram positive, type 3 gram negative, type 4 fungal. So this is the explanation. You can read it in 30 to 40 seconds. We have already discussed one such question 2, 3 questions back also. So just 30 more seconds for you to read the explanation and then we'll move to our next question. Next question regarding drug resistance and the use of antimicrobials in critical care. So MDR is defined as acquired non-susceptibility to at least one agent in three or more antimicrobial, not five. So this is false. Resistant strains of Enterococcus carry the PVL. No, MRSA carry the PVL, not the Enterococcus. So this is also false. MRSA can be treated with meropenem. No, MRSA is resistant to carbapenems. So this is also false. Tigecycline has activity against MRSA. This is right. You should, I already earlier told you that you should know what are your anti-MRSA agents. So tigecycline is one of the agent. And linezolid is highly effective when given orally. Yes, this is right because linezolid has more than 90% bioavailability. In fact, some of the studies they quote that it has got 100% bioavailability. So both your IV and oral dose, if patient can tolerate oral doses, it is equivalent. That is cheaper also, and patient doesn't require that much amount of fluids. So linezolid is highly effective when given orally. So let's see the explanation. You should be knowing, you should remember all the definitions of MDR, XDR, and PDR. MDR is resistant to at least one agent in three or more antimicrobial. And then XDR is non-susceptibility to at least one agent in all, but two. So you will have resistant to all, but only two category left. And when to all, it is pan drug resistance. So you can read this in next 30 seconds, and then we move on to our next question. So read the next question. It is most look like ICU doctor notice a hot swollen right knee. So patient has got arthritis, complain of pain in all range of movements, arthritis, deny any trauma and no history of previous joint problems. She is fit and well. She is having fever and ESR is more than 80. So regarding the diagnosis, a negative gram stain makes the diagnosis unlikely. So gram stain has got a very low or less negative predictive value. If you have a joint aspirate and if you have got a clinically, you can label the patient as having septic arthritis. So this looks like a wrong statement because a negative gram stain, it is a negative predictive value of gram stain is very, very low. Plain X-ray is often non-diagnostic. Yes, it is often non-diagnostic. CRP has high positive predictive value. No, your CRP can rise in any inflammatory condition, not just septic arthritis. A positive gram stain has a very high positive predictive value. Yes, if you see that your some organism is growing, that means there is infection. So positive gram stain, positive predictive value is very high, but negative predictive value is very low. And diagnostic aspiration should be performed within 2 hours. No, not within 2 hours. You can perform it anytime, as soon as possible, but you can perform it anytime. So we'll see false, true. Yes. So first statement was false. And I think this statement is also true. Yes. We have discussed that the plain X-ray is non-diagnostic. You just cannot diagnose a septic arthritis only on the basis of X-ray, plain X-ray. You will probably need aspiration and a MRI. So you can read the explanation. A white cell count of more than 25,000 with more than 90 neutrophils, 90% neutrophils is aspirated from the joint is a strong predictor for bacterial arthritis. Blood inflammatory markers are usually raised in all sorts of inflammatory conditions. And orthopedic input should be obtained without delay, as once the diagnosis is confirmed on gram stain and culture, the joint should be washed out as soon as possible to avoid destruction. You cannot wait for 2 hours. Next question, please read. Any of you who can answer me? So this looks like a case of septic shock. Low BP, tachycardia, and ta- patient is febrile. Already you know that the patient has a small thigh abscess, which has been incision and drained. She is sweaty and agitated. So intravenous dantrolene, I don't think this is a case of malignant hyperthermia. Administer beta-lactam and clindamycin antibiotics, yes. If you remember your surviving sepsis guidelines, the first thing you will do is after giving fluid to a patient, you will straight away go for a antibiotic. This is life-saving. You should administer your antibiotics in the golden hour of treatment. Urgent CT imaging of thigh, this I think we can wait. CT imaging may be required, but we can wait. Administer IVIG, no. First, you have to administer antibiotics and arrange urgent general surgical review. Yes, you can arrange, but first of all, you need to give first priority. They have asked for the first priority. It should be administration of your broad spectrum antibiotics. So this looks like staphylococcal toxic shock syndrome and acute toxin mediated multisystem disorder. This staphylotoxic shock syndrome, they will have multiple questions on this. And in my EDIC 2, I got a long case on staphylococcal toxic shock syndrome. So this staphylococcal toxic shock syndrome is very, very important because in India, usually we see very less number of cases, but it is a very important life-threatening problem in Western world. So you need to give broad spectrum antibiotics in this. Now, next question. Patient has severe chest infection. He consents to HIV test. Which of the following is not a AIDS defining illness? See, you have to remember all your AIDS defining illness as per your CD4 count. What happens when your CD4 counts drops below 500, below 200, and below 50? So oral candidiasis, they have in your ICU, if you are working in your ICU day and out, you will see so many patients on oral candidiasis also. Most of your immunocompromised patients who have received chemotherapy, who are suffering from some sort of cancer, they have oral candidiasis. So you will not label all your patients as AIDS. So this oral candidiasis can be there, but it is not a AIDS defining illness. All other things, mycobacteria, tuberculosis, Kaposi's, cerebral lymphoma, CMV, retinitis, all these are AIDS defining illness. So you have to remember all these things. These, as per the UK national guidelines for HIV testing, these are the AIDS defining illnesses. If you can read, I'm giving you 15 to 20 seconds because all these you have to remember anyways. In 15 to 20 seconds, you won't be able to remember. So you have to undergo all these questions later on. You have to assess all the responses and you have to remember certain things. So persistent oral candidiasis is not a AIDS defining illness, but one of a list of conditions that should prompt clinicians to consider HIV testing. So two questions left. So second last question. You can read and then we can discuss. What is the most likely diagnosis for the presentation which the examiner has given to you? 20 seconds for reading the question. Yes.
Thyroid storm.
Thyroid storm. Yes, very good. Now, why thyroid storm? You will tell me this. Very good.
The tachycardia and atrial fibrillation
Yes.
were very suggestive. And shock generally.
Shock. Yes. And the patient is febrile. She has got a temperature of
Yeah.
39. So we'll rule out one by one. So thyroid storm looks more likely. Then we go to option B. Decompensated alcoholic liver disease. You will not find patient having this atrial fibrillation
Acute
and
illness.
temperature. So rule out sepsis. Sepsis can be there. Patient has low BP, high heart rate. But what is the condition? What are the thing which rules out sepsis? Normal white count and normal CRP. This rules out sepsis. Then malaria. You will not have your atrial fibrillation in malaria. Ectopic pregnancy. Why the patient is not having ectopic pregnancy? Tell me. You have to rule out other things also. So in ruptured ectopic pregnancy, patient will not be mildly jaundiced. Patient will not be having atrial fibrillation. Patient can have temperature. Patient and your CRP will be high. So this probably most likely this patient is in having thyroid storm. All your features, mildly jaundiced, atrial fibrillation, agitated, high heart rate, low BP, and normal white cell count, normal C-reactive protein. So, what is the precipitating factor for thyroid storm in this patient? It is pregnancy. So, whenever a patient has second superimposed insult, most commonly infection, trauma, surgery, MI, diabetic ketoacidosis, pregnancy, parturition, she can have precipitation of this condition. So, pyrexia is almost universal. There is cardiac decompensation, tachyarrhythmias, neurological dysfunction, like you saw agitation, delirium in this patient, liver dysfunction secondary to cardiac failure, and nausea, vomiting, abdominal pain, and jaundice. These are all the features you will see in thyroid storm.
1358 double three
Pyrexia is
one
not
four one
seen
two.
in decompensated alcoholic liver disease, and sepsis is unlikely given the normal WBC and inflammatory markers. In patients with malaria, you will see fever, headache, malaise, GI, jaundice, and respiratory symptoms can be seen. However, tachyarrhythmias and cardiac failure are not normally present. So thyroid stop. Now, last question regarding the fluid therapy in intensive care unit. Which of the following statements are true? So this is a true false question. No, I don't think this is a true false question. This is a single answer question. Yes. So human albumin solution is the preferred resuscitation fluid in traumatic brain injury. No, it can worsen your
False.
traumatic brain injury. This is false. Use of HES has not been shown to increase mortality. No, it has shown to increase mortality. So this is also false. Third, use of HES is shown to increase incidence of AKI. Yes, this is true. In sepsis, if you give your HES, that is why HES is out of your ICUs these days. So this looks like true. FEAST trial supports the use of 20 ml per kg initial crystalloid in acutely in children. So in children, in adults we know, but I'm telling you for children, if you give your initial crystalloid bolus, it is detrimental. So always give very little amounts of your bolus in children because they can fall ill very easily. Safe study suggests the use of albumin as primary resistant fluid associated with worse outcomes in critically ill patients. No, the study suggested that worse outcomes in patients with traumatic brain injury, not all your critically ill patients. So you can read the explanation. Safe study, no over difference in outcomes. However, worse outcomes in patients with TBI and HES associated with AKI, we know, and FEAST noted a significant increased mortality in critically ill patients, in critically ill children receiving a fluid bolus 20 to 40 ml kg when compared to no bolus. Okay. So I think I'm done with the 20 questions. If there is any confusion, any question, you can ask me right now also and later also. All the best for your EDIC 1 exam. Sana, are you there?
Yes, I'm here.
If there is any question, if there is any doubt, we can take in 5 minutes. Otherwise, they can ask me anytime later also.
Sure, sir. I will get back to you if anything occurs.
Thank you. Thank you.
Thank
So
you
all the
for
best
today.
to all the exam going aspirants.